Thanks very much, Erwin. Dash, if it's all right with you, what I might do, because I noticed we're well ahead of schedule, and it looks like there's a panel discussion later, and I'm just imagining some people may not necessarily have joined as yet. Erwin, are you open to the idea of having a brief discussion now before we get to the panel later? And Michelle or anybody who's responsible for the organization, much more responsible than I'll ever be, please let us know if you're okay with that.
I'm fine with it. I wasn't expecting to be part of that panel. I don't think I'm on that program. Okay. I don't think so. I mean, I wasn't told. So
no, all good. All good.
Yeah. If you have questions for me, ask them now. Yeah.
Yeah, so I have some questions, but Dash, I'm interrupting. You're in charge. Do you have anything that you want to ask?
No, I'm not in charge. We're both in charge, David. And so you can start, but I would just encourage people to start putting the questions in the Q&A. So while David kicks it off, I will monitor the Q&A and then start feeding through some questions afterwards.
Fantastic. Yeah, and so I think the Q&A is happening in Hoover, and I can't see any questions there as yet. But Erwin, I'm going to kick things off if that's right with you. You really relayed that very, very thoughtfully, and I think gave us a good, clear idea of the complexity of this situation. Now, there's a lot of people, particularly when we're talking about elective orthopedic surgery, looking at what's happening in the US, particularly as it relates to managed care, bundled and packaged care, looking at implementation, particularly amongst organizations like Kaiser, where they're looking at measuring outcomes and assessing the quality of the delivery of care. And we've been, I guess, touching upon that in Australia and at least discussing it, but not at this point in time doing, at least as far as I can see, anything to disrupt Medicare, nor to look at ways of innovating and particularly, I guess, reimbursing for quality. So before I ramble on for too much longer, where would you see Australia deviating from a US managed style care operation, which is at least appears to be the way some of our organizations are heading? How would you see us deviating away from that and optimizing quality, measurement of outcome, and reimbursement for value, as opposed to fee-for-service style arrangements, which we currently have? I probably lost you in the long run.
No, you haven't. It's a great question, and it is something that we need to overt and discuss openly, because as you say, there are flavors of it coming to our shores, because the private insurers are looking at this very issue, and it is something that some instances of organization, but a lot of the private health networks are also thinking about. So I think the first point to make is that the US system is quite different to Australia. So in the sense that it's obviously a lot more privatized, and the funding models are slightly different. They don't have that Medicare baseline. They do have Medicare, but it's a bit different. So that's one thing. And so from that point of view, the private insurers in Australia do not have as much influence and power in that sense. Having said that, it doesn't mean that they can't get to that point. We can't, there is the potential. So I would say that the focus on value-based healthcare, the focus on looking at outcomes and paying for performance, and not rewarding poor outcomes, that is not unreasonable. I mean, that's something that's been studied, that's already here from the point of view of hospital-acquired complications, HACs, where both the public system and the private insurers no longer want to pay for hospital-acquired complications. That's already come, and that's slashed millions of dollars of the public hospital budget, as well as private insurance payments to hospitals, to private hospitals. So I would say for us as a profession, for surgeons, for people who are providers, that rather than wait for it to be imposed, we need to think ahead on how we come up with a model that benefits patients and not and is acceptable to the providers, but it doesn't actually is set up to save the insurers money because that's basically what's happening. We know in Australia, the private health insurance companies, I don't know if anyone's online, but I'll be frank about it. They are losing money and they are using what was previously put into place as quality guidelines, guidelines to ensure that people are practicing according to best practice. They're using those as financial rules to penalize hospitals and providers and not pay without any consideration of what's clinical. So I know this firsthand because I'm involved in negotiations with them. I've met their finance people and I've met the doctors. So when you talk doctor to doctor, the actual medical directors at the private insurance companies are very understanding. They actually agree with you that a lot of those guidelines have, 10, 20 years ago have been set up to encourage best practice. But when it comes to contract negotiation, they don't get a say. It's all financial people. And the financial people will say, this is just a accounting rule. It's got nothing to do with clinical practice. And I say, well, no, this is about, you don't want to pay for complications. I understand that as a principle, but there are some complications that are preventable and some that are not, or some that are just part of the illness. I mean, they don't care about it. So I would say what we need to do as a profession is to come up with a model that, number one, benefits patients. So one of the things that's happened is that there is a lot of variation in fee-for-service charges. For the same procedure in the same place, different providers and surgeons charge differently. And private insurance, and the problem with this is that it puts, for those who can afford it, no problems. For those who can't, it puts them off subscribing to private insurance. And that's partly, not the only reason why a lot of Australians have opted out of having private insurance. And the private insurance companies are very worried about this. So they want to ensure that whatever product they have can cover most of the costs. So there's minimal out-of-pocket costs for their customers, but they can't control what surgeons charge. So what they want is to offer some certainty for the customers. So if we can come up with a package potentially that benefits patients so that they know with certainty this is how much it will cost them without, and so some hospitals and surgeons and not just surgeons, obviously, some proceduralists have agreed on package deals independent of the private insurance. Now the private insurers have come in to say, actually, we can play in this space. So some of them have gone ahead and bought shares in hospitals, as we know, and they have come up with no fee, no out-of-pocket structures to control this. And that's heading down the managed care route, because that's the insurer being the funder, the provider, the regulator. I mean, they want to be everything, right? And a good example is Kaiser Permanente, and other health networks in America where they control everything. They are the insurer, they provide. And there are pros and cons to those models. I think if you do it well, so in New Zealand, for example, the district health boards, DHBs, I kind of like that. They are the provider, the regulator, the funder. They kind of run everything, but because they're public, they don't have that kind of commercial interest. And they're obviously a lot more altruistic. They are changing the system in New Zealand. It does have its flaws, but in Australia, we don't have that. There's a split, and that's not a bad thing to have the tension, to have people kind of let the market forces play out. But I think the private health insurers are trying to. They're saying hospitals and surgeons are not playing. We will just want to run everything. We're just going to start buying hospitals up and we're just going to do it all. And so we kind of need to push back against that. And so we need to come up with an alternative. I kind of know this because at St. Vincent's, I've been talking to the private division about how do we work with our surgeons to kind of fight this, to compete, because otherwise we'll lose out, because patients will go to the insurers, because the insurers are saying, we're going to give you this package, no out of pocket at all. We're going to get your surgery done, and we're going to ensure that you're going to have, we're going to penalize surgeons for bad outcomes, And so we need to come up with a model that is not managed care, but that is acceptable to the patients, and also acceptable to the insurers. Now we can come up with a model to push the insurers out. To be honest, I've always kind of thought about that. Why should patients pay monthly a fee to private insurance, and we then become slaves to that whole model? Why not for them to pay someone else, pay a group of surgeons, or pay the hospital, or pay someone else? Now it's complex because there are insurance laws and APRA and all those things, and then APRA, APRA, not the hospital, not the practitioner APRA, but it can be done. I mean, it's been done, and so it's something that we're looking at. And obviously, the private health insurers are really worried about that. But yeah, no, I get your concern around managed care coming in and dictating what doctors can and cannot do, and not paying for things. It's an extreme example of pay for performance and quality incentives being misused and abused, and we need to kind of push back against that. Sorry, that's a long answer.
No, it's all good. It's all good. I guess and Dash, you interrupt if you want to, but there's a couple of points in there that I just want to come back to, and particularly given hopefully the dialogue of the day is around how we best innovate and do that in a collaborative way. Obviously, there are big issues there in terms of out-of-pocket costs and lack of price transparency. And I think to a large extent, much of what we're currently doing is not driven by what the patient needs and what the patient ideally would benefit most from. You mentioned at the start of your response that we should be the ones driving this conversation. We should be the ones innovating. How do you get the right people around the table? And that this, obviously you have the health insurers and the surgeons there, but not necessarily be driven by them, but be driven by clinical need, patient need. And how do you start that conversation so that it happens in a way that ultimately is then not dictated to by those people who are worried about infiltration of health insurers buying hospitals and driving the care in a direction that may not necessarily be best for patients?
Yeah, and I think your question has the answer embedded in it. It's starting with the patients. And so it's basically talking to the consumers, the patients, asking them what do they want. And clearly organizations like ours, the private health insurance, they've got focus groups with people like that. And they know that people want, number one is the health, right? So they want the best outcomes. So they want to get the best surgeons, get the right procedure, and get the best outcomes. But number two, they want to have financial informed consent. They want to have clarity of the charges. And, when I say, let's come up with a way to improve that, what I'm saying is the current system where the patient gets referred to a surgeon, and then the surgeon has his or her own anesthetist, and then they go to a hospital, and the patient gets multiple bills at different times, again and again. And it's hard for them to keep track. They never told, okay, for this, you're gonna have to pay 15,000. They just don't know, because the surgeon charges something else, and this is just will charge something else, the hospital will charge something else, insurers may cover some or none of it. And again, so the ideal, obviously, and this is where health insurers want to play in this space, and hospitals too, to help, is to say, this is one bill itemized once. And you get it in front before you get the procedure, so you know exactly how much it costs. And we can, and it doesn't matter which surgeon you go to, this is the same bill. And in the back end though, the surgeon, so depending on how you, what kind of model you have, you can have different kind of contracts. But I think the key here is consistency for the patient. I think that is number one. But clearly the patient is not just the only person. You also need to work with the provider. So so you want to have something that's also fair for the surgeon, that they don't lose out, And I think for all of us, we need to think long term here, because a lot of surgeons are really worried that if they kind of take one step towards this direction, it's going to be a slippery slope towards losing all control, and they're going to be told what to do and what they can charge. And that's not necessarily the case. But if they refuse to move, if none of us say, if all of us say, "No, we're just not going to make any changes," we will get taken over, because the insurers are going to do it no matter what. They're already doing it, and they have big plans, because that's the only way they can survive, actually, is to move into this space. Because I think as long as they just stay as insurers, they're losing money. So they have to have alternative models of care and business models to move into the 21st, 22nd century, and they're already doing it. And so as hospitals, as surgeons, we need to kind of think about how do we also offer something else on our own terms. Does that help? So there are some questions in the Q&A now, actually. So just kind of.
I think you've answered quite a few of them in your responses already, though, and I'm conscious of our time boundary for the next speaker, but I think we could listen to you all day, Erwin, and how you've highlighted quite a lot of the complexities that are required to disrupt and innovate in this space. So thank you for those responses. But David, I wonder if you now introduce our next speaker, and then Erwin, are you going to stay around for the panel, or are you going to, do you need to leave? I
do have to leave, sorry.
Okay.
I've got meetings. What time's the panel?
9:20 till 9:50.